My name is Raphael Cohen-Almagor. I am a medical ethicist. I conducted research on end of life since 1991. I conducted fieldwork in 9 countries. I'm a co-drafter of the Israel Dying Patient Law, and I've been an advisor for several governments in Europe, Africa, North America, and Australia. I prepared a PowerPoint that I would like to share with you. So it is titled Guidelines for Physician Suicide. I'll try to be very concise in the limited time that I have. And I'm going to explain what do I see as the best way to go about physician-assisted suicide. In my research, I'm trying to find a golden mean between various interests. We'd like to take into consideration the will of the patient and also the state duty to prevent abuse. Liberal society has a duty to its citizens to ensure that the most vulnerable people in society will be secured. So when we are condoning end-of-life legislation, we have to be extremely careful. After all, human life is at stake. The patient expressly wishes to end his or her life and is made a signed declaration to that effect. The expressed wish to die should be voluntary, made in sound mind, and signed in the presence of a witness who is not related to the patient's family, nor to the medical team that treats the patient. The decision should not be made by the patient's family or as a result of family pressures. It is the task of social workers to examine to what extent the patient is affected by external pressures. There should be a cooling off period, so it should not be just a one-off wish. It has to be a repeated wish. And I'm claiming there should be a cooling off period of 14 days between the first time that the patient expressed a will to die and the second time. We should ensure that there should be a second opinion. So the decision-making process should include an expert who is going to verify the medical diagnosis in order to minimize at least the chance for misdiagnosis. It has to be a specialist who is not dependent on the first physician. And that expert physician has a dual responsibility. He needs to verify that the patient's desire to die is genuine and voluntary, and that the attending physician was correct in diagnosis that she made that the patient is indeed suffering from intractable, incurable, and irreversible disease. We need to ensure the physician independence, and therefore it is advisable that the identity of the consultant, of the person who provides a second opinion, will be determined by a committee of specialists who will review the request for physician-assisted suicide. At times, the patient decisions might be influenced by severe pain, and therefore the role of palliative care can be and is crucial. The attending physician should inform the patient of all feasible alternatives, and she should consult the palliative care specialist who will inform the patient about relevant measures to help the patient cope with pain and suffering, including comfort care, hospice care, and pain control. The patient must be informed of his or her situation, the limited prognosis for recovery, the expected escalation of her disease, and the degree of suffering that may be involved. There must be an exchange of information between physicians and patients. Physicians should not suggest assisted suicide to the patient. Instead, it is the patient who should have the option to ask for such assistance. Any reluctance shown by patients regarding this issue should be honored and respected. Sometime prior to the performance of the physician-assisted suicide, the physicians and the mental health specialists should visit and examine the patient. They will verify that this is the genuine wish of the sound mind patient and that the person is not depressed, is not coerced, and is not influenced by a third party to end their life. The patient must be able to rescind his decision to pursue physician suicide at any time and in any manner. Physician-assisted suicide may be performed only by a physician in the presence of another physician. The decision-making team should include a lawyer who will examine the legal aspects involved and ensure there is a protocol in place which will prevent possible abuse. At the very least, a public representative should be involved if that person is not a lawyer. Physician-assisted suicide will be conducted as a last resort after exhausting all treatment options that could potentially bring the patient some relief and reduce her suffering. Physician-assisted suicide may be conducted in one of three ways, all of which should be discussed openly and decided upon by the physician and the patient. The first is oral medication, the second is self-administered lethal intravenous infusion, and the third, self-administered lethal injections. Physicians may not demand a special fee for the performance of physician-assisted suicide. There must be no financial incentive to perform or assist with the procedure, since the motive for physician-assisted suicide is humane. There should be extensive documentation in the medical file of the patient, including the disease diagnosis by the attending and the consulting physicians, attempted treatments, the patient reasons for seeking physician-assisted suicide, the patient request in writing or documented on a video, documentation of conversations with the patient, the physician offer to the patient to rescind his or her request, documentation of discussions with her beloved people, and the psychological report confirming the patient's condition. Each report should be examined by a coroner following completion of the physician-assisted suicide. The drugs required to end one's life are known. Physician will be allowed to use only the lethal medications authorized by the Ministry of Health. Pharmacists should be required to file every time and again lethal record of the lethal medications that were sold. Physicians should not be coerced into these actions if it conflicts their conscience. No coercion should be involved in the process. Conscientious objection should be respected, also of the patients. A medical association committee should be established to investigate underlying facts of reported cases, to explore whether there were cases which did not comply with the guidelines, and to inquire whether there were unreported cases. Significant sanctions should be taken to punish those professionals who violated the guidelines, who did not file reports or engage in the involuntary termination of life without consent. Physicians who fail to comply with the guidelines should be charged, and procedures to sanction them should be enforced by the medical disciplinary tribunal. The sanctions should be significant and include revocation of the physician's medical license. An annual report should be published, documenting all cases. Thank you very much for your attention.